So we would next go to Dr. Richard Fernandes Almeida, who shall be talking on his abstract on CAPD. Dr. Richard, please share your screen.
Perfect. All right. Well, for those of you who don't know me, I'm Richard Fernandes Almeida. I am a interventional nephrology fellow at the University of Wisconsin in Madison, and I want to thank you all for having me present our early experience in the successful utilization of an interventional nephrology in an urgent start peritoneal dialysis program. To start off, the growth of peritoneal dialysis in the United States over the recent years has been only modest. And this is despite the quality of life benefits, the potential superior outcomes over in-center hemodialysis, and the financial benefits spurred on by Medicare incentives in 2011, and then subsequently the executive order in 2019. There's been a growth of PD over the last 10 years of about 6%. And this is despite all that I've stated. A reason for the modest growth of PD utilization could be because of inadequate utilization of urgent start PD. Due to difficulty expediting the PD catheter placement. Many patients who would otherwise be suitable for PD would need to be initiated on hemodialysis via a temporary or a tunnel hemodialysis catheter, and only a subset of these patients would ultimately end up being transitioned to PD. As for the definition of urgent start peritoneal dialysis, it is all peritoneal dialysis initiations for incident ESRD that begin within 2 weeks of PD catheter replacement. Our study was essentially designed by having a multidisciplinary group of dialysis nurse educators, social workers, care coordinators, nephrologists, and interventional nephrologists design both the protocol as well as the program, and have patients streamlined to be set up for urgent start peritoneal dialysis at the discovery of incident ESRD upon admission to the hospital. As you would clearly understand, the most crucial and rate limiting step for the proper functioning of an urgent start peritoneal dialysis program is the expedited placement of a PD catheter. And this essentially requires a dedicated provider and a cath lab available at short notice. The goal of our urgent start PD program was to have PD catheter placements within 24 to 48 hours of consultation. Over approximately a 1-year period, we had 8 patients initiated on urgent start peritoneal dialysis. The average age group was 20 to 65 years, and the male to female ratio was 5:3. As can be seen in the graph on the left side of the page, all the patients with the exception of number 6 and 7 had PD catheters placed within 24 to 48 hours. Of note, these patients did not require initiation of PD urgently, as they were initiated on hemodialysis via a temporary hemodialysis catheter. They subsequently underwent a PD catheter placement while inpatient and transitioned to urgent start PD. Hemodialysis was chosen as the initial RRT modality in patient 6, as there was uncertainty of a diagnosis of ESRD. And as for patient 7, hemodialysis was done while awaiting laparoscopic PD catheter insertion due to concern for risk of failure of percutaneous insertion due to a complex transperitoneal surgical history. All patients with the exception of 3 and 5 were initiated within the 14-day time frame from PD catheter placement, which defines urgent start PD. These 2 exceptions were discharged to initiate urgent start PD as outpatients, but they were felt by their outpatient nephrologist to be stable enough to delay initiation of PD and allow for more time for the tunnel healing. As for patient 2, they had a non-urgent PD catheter placement laparoscopically. but subsequently had been admitted to start PD on day 7 as an urgent start due to the development of uremic symptoms. As for the outcomes at 1 year into the program, of the 20 patients who underwent inpatient options class, 12 required renal replacement therapy. Of the 12, 8 were started on PD, 5 of whom are doing well on PD. One patient was overwhelmed by PD and transitioned to hemodialysis after 21 days of PD. And another patient developed a pleuroperitoneal leak and was transitioned to hemodialysis at 2 months of receiving PD. Another patient was poorly compliant with PD and subsequently transitioned to in-center hemodialysis at 9 months. Of the 4 patients who were started on hemodialysis, 2 preferred peritoneal dialysis. However, they were found not to be suitable candidates for PD at the time, one of whom had a complex housing situation with plans to eventually transition to PD, and the other had a complex intra-abdominal surgical history and was unable to have a PD catheter placed in the time frame to initiate urgent start PD. As for complications at 1 year, we had no reported catheter malfunctions, hernias, pericatheter leaks, exit site or tunnel infections, or early peritonitis. One patient did report drain pain that responded well to tidal PD, and another patient had a pleuroperitoneal fistula which required transition to hemodialysis. In conclusion, interventional nephrologists and cath lab availability to place PD catheters in a timely manner is crucial for the successful implementation of an urgent start PD program. And I hope to see this being implemented more and us doing more urgent start PD all over the world. Thank you.